good evening, good afternoon, everyone. You are welcome to this year's edition of Brain Awareness Week 2026, and the last day that we're going to mark it with this set of presentations, the Multidisciplinary and Integrative Neuroscience Evening. And you're welcome, and we hope you will enjoy the presentations. We have a lineup of individuals with expertise in their field to share with us what they have for us. All right, so we'll wait just a few minutes, maybe 2 or 3, up to 5 minutes before we begin. Thank you very much, and you're all welcome. We have Mrs. Murorwa starting out at 5:40, then whenever she is done, if there are any questions, we'll take them. The next person to speak will be Mrs. Ripagan, and then Ms. Mariska van Wyk, and you'll have to bear with me technically for that one because it's a recorded talk, and I'll have to get that on. Then we have Ms. Maria Kambongi, who is our neurophysiologist. Mr. Munashe comes next. I will give a very short update on latest interventions in epilepsy, and that should wrap up the evening with questions intervening. Thank you very much. Thankfully, we have quite a few participants. We're nearing 40 at 39 over here. I'd like Dr. Amesho to raise her hand so that I can also make her a host.
Myself, I am Dr. Josephina Mesho, and we initially did this initiative last year with Dr. Salah, with her institute, of course, Benguela Neuroscience Institute. And we have yet another privilege to bring this brain awareness to Namibia this year, and hence why we created this event specifically for today. But I mean, it has been ongoing for the past week. So this webinar is basically just to speak about our topic of discussion, which is epilepsy in the community. And we have a few guests that are going to join us this evening also to give their talk. And welcome to everybody. Welcome to the talk, everybody on the webinar. Thank you.
Super, thank you, Josephine. Josephine will help me to co-host. And I would like us to start without further ado. Our first speaker is going to be Mrs. Martha Murorwa, who has been a friend of neuroscience and a friend of the Benguela Neuroscience Institute. She has a special interest in neural conditions and neural issues, and she kindly agreed to speak with us. And today she's going to talk to us about the program they have for medical professionals at Nedbank. Mrs. Murorwa, as I said, is the director of Nedbank Namibia, and is a dynamic person, a leader in the community, a mover and shaker, and you've seen all the good that Nedbank does within the country. She's very busy this weekend, and we're so glad that she has shared some of her time with us. And without further ado, Martha, Mrs. Murorwa, if you would kindly come on and start your presentation. I'm going to try to unmute you if you're having any trouble unmuting rather. Share your screen and please go ahead.
Okay, thank you very much. Can you hear me?
Yes, I can hear you clearly.
Okay, okay, that's great. Honorable guests, distinguished practitioners, researchers, partners, and friends, good evening, and thanks, Dr. Aminata, again for bringing NetBank into the mix and also for bringing me into the mix. It is really an honor to join you once again as we commemorate Brain Awareness Week, a global initiative championed by the Dana Foundation and here in Namibia, passionately carried forward by the Benguela Neuroscience Institute under the leadership of Dr. Aminata Sala Shirongo. This platform continues to grow in importance, bringing together neuroscientists, medical professionals, policy influencers, and community leaders to deepen our collective understanding of the most powerful organ in the human body, which is the brain. Over the years, this has become a beacon of excellence in our nation, drawing respected experts who unpack topics such as neuropsychology, neuroethics, neurooncology, cognitive development, and brain healthy lifestyles. These conversations remind us that brain health is not a medical concern alone, it is a societal imperative. Brain health affects every dimension of our lives. It determines how we learn, how we make decisions, how we interact, and how we contribute to the society. As Dr. Aminata Salah Shirongo has and her team consistently highlight, the brain health is often overlooked, yet it influences every aspect of human potential. And I must say here that last year I had the privilege of inviting Dr. Aminata to talk to my leadership team, the EXCO plus also the management senior managers. And it was quite impactful in terms of what we as at workplace experience, the stresses that we experience, how it emanates and how and the impact that it has got on the brain and also on productivity. So for me, when we strengthen the nation's understanding of brain function, we strengthen its capability. Again, when we also empower practitioners with the tools to diagnose, treat, and innovate, we build resilience. When we educate the public on cognitive well being, we uplift communities. This is nation building in its purest form, and I must really say once again, thanks to Dr. Aminada. I mean, we look at all the aspects of our body, we focus on everything, but we are not focusing on the brain, and this is really nation building in its purest form. So some may ask, what does a bank have to do with neuroscience? And obviously, the answer is very simple. It's everything. Banking is fundamentally a cognitive activity. Every financial decision, from financial family planning for school fees to a business investing in expansion, requires judgment, risk assessment, memory, and emotional regulation. These are core brain functions. In fact, if we have emphasized as we have emphasized before, stress caused by financial instability directly impacts cognitive performance, decision making, and mental health. A nation cannot thrive if its people are financially strained and cognitively overwhelmed. That is why NetBank is deeply committed to enabling financial well being as part of our overall well being. Obviously, NetBank's ongoing support for Benguela Neuroscience Institute is not a once-off sponsorship. It is part of a deliberate effort to contribute to a healthier, more capable Namibia. Last year, our support enables a successful Brain Awareness Week event that convened leading specialists from Namibia and abroad to share in critical research and insights. We therefore remain committed because we recognize the Institute's vital role in advancing neuroscience research in Namibia, driving public education and brain health, supporting early detection and treatment of neurological conditions, and creating a multidisciplinary platform that bridges science, technology, medicine, and public well being. When institutions like Benguela thrive, Namibia thrives. So we also recognize the unique financial pressures faced by medical professionals, long training pathways, the cost of equipment, the challenges of establishing a practice, and the need for tailored financial management tools. That is where the NetBank medical value proposition comes into play. And I want to highlight some of the specialized financial exclusive CVPs that we have designed for medical professionals. And this includes and is not limited to preferential banking solutions, dedicated relationship bankers, financing for medical equipment and practice expansions, cash flow support tailored to irregular income cycles, because we understand that medical professionals do not have, in most of the instances, fixed monthly salaries. So their income is obviously coming in irregular income cycles, and therefore we have tailored a cash flow support program that can support the medical practitioners. Investment and retirement planning aligned with medical career trajectories, and flexible digital tools enriched by human guidance when needed, reflecting our approach. What we also say in terms of the digital um, tools that we have is that we are human when you need it, and we are digital when you want it. We have designed this suit because we understand that medical professionals are a lifelong journey of service, and they deserve a financial partner who understands their world. From medical interns to specialists, dentists, pharmacists, vets, physiotherapists, and beyond, our offering grows with each stage of your professional journey, ensuring your practice and personal finances remain resilient and future ready. Supporting the healthcare sector is more than a commercial opportunity. It is an investment in the well-being of our nation. And I must also say, I mean, we have, after creating the whole medical product offering, we are also venturing into financing hospitals. And recently, we have also financed one of the tier one hospitals in Namibia, Lady Pohamba, and we are more than able and willing to to work to walk the path with all the medical practitioners. As we reflect on this year's Brain Awareness Week, I want to acknowledge the Benguela Neuroscience Institute for its unwavering dedication. Your work illuminates the path towards a more informed Namibia, one where science and society move forward hand in hand. Ladies and gentlemen, let us continue to champion brain health, advance scientific understanding, and build a Namibia where every citizen thrives, and not only economically, but mentally, emotionally, and cognitively. Together, let us invest in a smarter, healthier, and more prosperous Namibia. And once again, thank you very much, Benguela Neuroscience Institute, for what you are doing to Namibia. We will support you, and we will continue to believe in the job that you are doing, that it will bring the necessary change. I thank you.
Thank you so much, Martha. That was a fantastic start to our electronic get-together here to discuss brain science, brain health, and we are so happy and so inspired by what you have said. Yes, indeed, this is nation building, to use your own words, and a smarter, healthier, more prosperous Namibia is ahead with all the efforts that we are putting in. In fact, one of the things I'd never heard of was that Nedbank had financed Lady Pohamba Hospital. That is great news. This means that, you know, into the future, we can advance.
Absolutely, absolutely. That was really definitely one of our flagship financing. And we are talking about millions of financing that went in three-digit numbers that we are talking about. So it's really something that we are proud of.
Indeed, that is highly impressive. We are all proud of Nedbank for that. With that knowledge, we have a bright future ahead with all the institutions that we hope to put up for ourselves here. As we know, the world is not getting any easier, and there's almost nowhere to hide and nowhere to go when disaster strikes, as we saw during COVID. So we better get our own act together and provide services for ourselves. And so I applaud Nedbank and you know, the proprietors of Lady Pohamba Private Hospital for being able to put together, you know, such a feat within Namibia. And upwards and onwards, and here's to better days. Mrs. Murorwa, thank you so much for having spoken to us.
Okay.
Mrs. Murorwa, thank you for your support. Thank you for helping to bolster Benguela Neuroscience Institute. We shall continue to make you proud and try to come up with relevant socially needed programs to advance the cause of brain health and brain science. And as we all know, brain health is the health of the entire body. The brain is the CPU, it's command center, it's the motherboard. And without the brain, there is no person. So we thank you and we appreciate you and the efforts of yourself and your team.
Yeah, and without the brain, you will not have any bankers. So thank you very much.
That's a good one. Thank you very much. We appreciate it and we are glad to hear our bankers have good brain health.
Yeah. I will
Very
maybe
good.
stay on for a few minutes and thereafter I will just silently
We
disappear.
appreciate. One of the things I didn't know was that bankers could be humorous, and so you've changed that preconception now. Thank you so much.
Thank
Highly
you.
appreciated. Okay. All right. So our next speaker is going to be the Epilepsy Association of Namibia's chairperson, Ms. Hermina Riphagen. If you will kindly unmute yourself, and you can tell us a little bit about your association and what they're doing in Namibia with regard to epilepsy. One of the reasons I thought it was important to bring in Ms. Riphagen is that a lot of times as medics or as health professionals, we talk about other people and their diseases or issues that they may have without including them. And so I thought it was important to have in our midst someone who walks the walk, talks the talk, is in the community doing that. So Ms. Riphagen, without further ado, please go ahead and give us a few words. If you want to share something, you may share your screen, and we are all ears. Hello, Mina.
Hello, here I am.
Okay, you're welcome. Please do go ahead. Tell us a little bit about yourself and then about your association. We appreciate it. Thank you.
Thank you. We are not in the high ranks of the medical associations. We follow and help people with epilepsy to live in their community after diagnosis. So we are an organization, we do awareness, we do advocacy, we do epilepsy lifestyle management, and we do training. We follow the path of the person with epilepsy and see that they get to services, that they get to go to school, that they get to be incorporated in their communities, that they can get a job, that they have a healthy lifestyle, which we see as our contribution to living with epilepsy, because the healthier the lifestyle, the better the brain, the better the treatment, the better the outcome. Those are the jobs we do. But I want to explain something else about the organization and the structure within the international situation with epilepsy organizations. And there's a bit of letter soup in it. We are also a chapter of the International Bureau of Epilepsy, which is the psychosocial side of helping people with epilepsy. And then there's also another organization, the ILAE, the International League Against Epilepsy. And most countries have both these chapters in the countries. We don't have, and that is the medical side, the neurological side of the epilepsy organizations. It is recommended that such an organization is formed in Namibia to pull together and use the resources of the International League Against Epilepsy, the ILAE. We've tried before to have such an organization established here. It has not worked yet, but it's a very valuable resource for the medical side, neurological side of epilepsy and its treatment. So there is a call to try and get an ILAE organization established as well. We are at the moment working on a program that we call Personal Advocates. That is where we try to put a personal advocate in every community who can help persons with epilepsy to navigate their life, to assist them in access to services, in employment and education, in their social welfare. But we would like these advocates to be of the community in the language, in their own language, and in their own cultural background, which is important to us because we believe that it is difficult to ask what you need and to get what you want if you cannot speak it in your own language. So these advocates will then assist people with epilepsy through their journey with living with epilepsy. This program is rolling wider and wider. We train trainers to train advocates in the communities. It's difficult to find the right people to train because they will carry quite a burden to get this established. And it is a delicate path to walk. We're also thinking of making it wider for other neurological conditions, to do this as a cooperative program. We don't have the nice word yet, but we hope that we can reach more people effectively, because it's quite finance-wise, cost-wise, it's quite debilitating to try and help a few people with small tasks every now and then. It just does not work out, and we would like the advocates to be in the community where they can operate quickly and freely, and that it is not so much a burden on the service provider to get the finances to keep permanent and complicated, actually, services there, because we don't really need that. We just need the support for the persons with epilepsy. That is more or less what I can tell you now.
Well, thank you very much. We really appreciate you coming into our fold here and telling us about your work and your challenges. And in unity is strength, and communication is everything. So we did not know what your challenges were. We now know them. Perhaps together, if we hold hands, we can get something done. So I propose that after all these events are over, that we can get together and talk. We talk about your challenges and see how we can also, as a community, contribute towards making your organization stronger. If you want to set up an ILAE, I think even medics would be interested in ILAE because it's essential to have, so that Namibia can be well represented internationally in the International League Against Epilepsy. We're open to conversations. So let's talk about it. Benguela Neuroscience Institute is here. Epilepsy, neuroscience and epilepsy are inextricable from each other. So, as I said, the invitation is open for you to come and chat with us.
Thank you very much.
All right. Well, we shall move on to the next aspect of the webinar, and this is where we had invited Ms. Mariska van Wyk to give us a talk on brain health and nutrition. Ms. van Wyk, from my experience, is one of the best dietitians that I have met in Namibia. She is excellent, and she had to travel. Many people are traveling today, but she did record something for us. So I'll play some of what she has recorded up to maybe 10 to 15 minutes, and then we'll stop it there and then add another few minutes because she has added a small tag on that is relevant to epilepsy. And after that, we'll move on with the next item in the program. I'm going to now try to share the video, and I hope it will work out.
This is a recording, but we are traveling for Easter weekend. We are going to look at nutrition for optimal brain health for our brain awareness campaign. I am Mariska van Wyk, practicing under Van Wyk, married Oosthuizen. So a little bit about myself. First of all, I am a wife and a dog mum, as you can see. And if we look at my qualifications, I started with a BSc Dietetics at Port University. I also completed a postgraduate diploma in diabetes at the University of South Wales. I also did a master's in diabetes at the University of South Wales, as well as a postgraduate diploma in medical education. I have a true passion to train and to teach. My professional roles, I am a dietitian and diabetes educator. I'm also an insulin pump and CGM specialist. I'm the founder of my practice, Blue Care Dietitians, and then my practice led me to Foundations for Farming. I was sitting in my practice one day and I thought, I can't just hand out guidelines to patients and tell them, do this, eat more vegetables. I need to teach them. And I went to Zimbabwe and I was trained in Foundations for Farming. I'm now the country coordinator for Foundations for Farming in Namibia. I am myself a trainer of Foundations for Farming, as well as an I Was Hungry trainer. And that is where we go to villages and teach them how to grow their own food and to be self-sustainable. I'm currently also a trainer in Aname training, and that is natural health or natural medicine in the tropics, where we also teach people who's far away from doctors to use the resources that they have available to help themselves medically. If we look at an overview of this presentation, we will look at brain nutritional fundamentals, as well as nutrition for cognitive performance. We're going to look at key nutrients and mechanisms, as well as the gut-brain axis. We will look at a few dietary patterns as well as lifestyle factors, and we will have a few words on the epilepsy diet. Kofi Annan said that it is my aspiration that health finally will be seen not as a blessing or to be wished for, but as a human right to be fought for. So if we look at the core principle of nutrition and the brain, we see that brain function is highly nutrition dependent across the lifespan. Nutrition influences brain development, neuroplasticity, neurotransmission, and cognitive resilience. So cognitive health really is the ability to think, to learn, to remember, and to function independently, and nutrition plays a key role. If we look at the critical early life findings, we see that nutrient deficiencies already during pregnancy, infancy, and early childhood leads to lifelong cognitive impairment. And these processes that are affected are neurogenesis, synaptogenesis, and myelination. Brain development and the decline follow a life course model. It's not just isolated stages. If we look at early nutrition, that is where structural brain development is involved. Adult nutrition plays a role at performance and preservation, and midlife determines our dementia risk. If we look at nutrition for cognitive performance, we see that nutrition affects attention, decision-making, mental clarity, as well as resilience to stress. And if we look at how deficiencies play a role, an iron deficiency can cause a reduction in oxygen delivery that is causing fatigue and poor cognition. The B vitamins play a role in neurotransmitter synthesis, and omega-3 that's very important in brain function. If there's a deficiency, it has a reduction in neuroplasticity, and that results in a reduced productivity, reduced attention span, as well as a reduced executive function. So if we look at brain and the glucose, we see that the brain uses glucose every second of every day. And that is why all of us need to have 4 to 6 millimoles per liter glucose in our blood. So if we just appreciate the basic anatomy again, when we eat, we see that blood glucose is in, or it's broken down into blood glucose that's in our bloodstream. The liver stores and makes glucose that also produces glucose when we are not eating so that the brain can still function. And the pancreas controls glucose storage and production. We know that the beta cells measures these glucose and it makes insulin according to that so that that glucose can be transported. The brain also needs insulin so that it can use glucose. And when our blood sugar drops, the alpha cells tells the liver or the muscles to produce glucose. There's also gut from the glucose when we eat. So what is important is that we maintain stable blood glucose. So the brain requires stable blood glucose supply. High refined carbohydrates causes a rapid glucose spike. It crashes, so you feel flat after having high glycemic foods, where you then feel that brain fog that will influence your concentration and also decision making. So it is important if we look at cognitive performance that we know that it's not neurological only, but that it is metabolically driven. So this is where you can then also see that if we skip meals, we have a drop in our blood glucose, and luckily the liver can step in and provide us with glucose, but it is ideal not to skip your meals, and breakfast is a very important part of a proper cognitive function during the day. We also see in the practice that patients living with diabetes, if they have a breakfast, their blood glucose is more stable during the day than those skipping breakfast. But in essence here, we can see that the brain needs glucose all the time, but it should be a steady, stable supply of glucose. So if we look at an unhealthy diet that provides too much glucose and a rapid increase of glucose in the bloodstream that the brain doesn't want, it's the unhealthy diet. So what people eat today is way too much sugar and salt, and sugar is not only coming from sugar, but from refined carbohydrates, like we see in these pictures, especially hamburgers, pizzas, things that's made with flour, the cereals that's packed with sugar, and then all the sweet foods and carbohydrates in the picture showing you lots of sugar that we consume that is really not necessary and is not good for brain function for a healthy brain. We also eat too much unhealthy fats. The fast food and takeaways are predominant in patients' diets today. People don't usually take lunch boxes to work anymore, and they will wait until they are hungry, so until they have that drop in their blood sugar, and then they would go and buy something unhealthy instead of having home-cooked foods. Processed foods are also very unhealthy. It causes inflammation of our cells. And we know that we should stay away from processed foods because it doesn't provide us with the micronutrients that we need, as well as it has a lack of fiber. These refined foods are usually white bread and pasta, as well as the highly processed flour that I already mentioned. And it often has added sugar where the flour is already broken down into sugar. It also contains added sugar. So these foods are not natural. We should not eat this. It's not how God designed food. It does cause poor health, and it does influence our performance at work. So it also causes malnutrition. And if we look at the phases of malnutrition, you can have a normal body weight but have hidden hunger. That is when we have micronutrient deficiencies because of an unhealthy diet. You can also have wasting, where there's a deficiency in calorie intake. Stunting is another form of malnutrition. Underweight is a form of malnutrition. And then we also know obesity is the other side of the coin of malnutrition. And then today we also see the double burden when there's stunting and obesity involved. So the impact of stunting is severe because it reduces brain development. It lowers school performance in children. And it does have an increased disease risk, and it reduced adult productivity later in life, as well as even their income, because they can't perform well at work. And it is considered as one of the most important indicators of child well-being globally. So if we look at the important nutrients for brain function, it is all three the macronutrients, your carbohydrates, proteins, as well as fats, as well as the micronutrients. They play a key role in brain function for all 15 important vitamins and the 16 minerals that we have. So if we look at the micronutrients, fats, in all the studies, the omega-3 are mentioned first for brain health, especially EPA and DHA, a minimum of 500 milligrams per day, and that helps with neuronal membrane integrity as well as neurotransmission. It reduces neuroinflammation and increases neurogenesis. Am I not going to say that word today? Saturated fats are very unhealthy. We know it contributes to oxidative stress, as well as the refined carbohydrates that I already spoke about. It increases hippocampal inflammation, reduces memory, and it does increase Alzheimer's risk according to evidence. The proteins, there's mixed evidence overall about the overall cognition, but it does have a positive association with memory, and then also executive function. And some studies were mentioned, but it indirectly affects brain health, because if you have an unbalanced meal, when there's not proteins involved in the meal, we usually overload with carbohydrates, and that then causes a nutrient or a meal intake that is too high in glucose that the brain does not want. So it's important that we always include protein in each diet. If we look at carbohydrates and brain health, it is essential for brain energy, but like I mentioned before, if our blood sugar levels are unstable, it does cause impaired cognition, and we want a stable supply of glucose. So we use low glycemic foods with frequent meals and balanced meals to have a sustained energy production throughout the day. And that will help us with optimal brain function and performance at work. If we look at the micronutrients, the five that's mentioned throughout the studies are your B vitamins, vitamin D, iron, the antioxidants, as well as the polyphenols and flavonoids that we will look at after this slide. So the B vitamins are helping with neurotransmitter synthesis, as well as myelination. And if there's a deficiency in B vitamins, we can suffer from cognitive impairment. Vitamin D is very important in brain health. We've seen that low levels increase dementia risk, and it is also associated with impaired cognition as well as impaired executive dysfunction. Iron deficiency. Iron is responsible for oxygen delivery to the brain, so that deficiency can cause fatigue and poor concentration, as well as long-term developmental deficits. The antioxidants, especially vitamin C, E, and polyphenols, play a crucial role in brain health. It reduces oxidative stress, it reduces neuroregeneration, and it is associated with decreased cognitive decline. If we look at polyphenols and flavonoids, it increases memory and language performance. It does reduce, again, the cognitive decline risk. And the mechanism behind this is because of all the anti-inflammatory and antioxidant function that it has on the brain. So let's look at how we can consume micronutrients in an easy way. We can just think of eating a rainbow to have that diet variety with all the micronutrients that I just mentioned. So we don't have to remember all these huge words like the red veggies, tomatoes, red bell peppers, the fruits, watermelon, grapefruit. It produces or provides lycopene. So if we can just think of the rainbow, we know we get all the micronutrients, because the red ones helps with brain cell protection as well as inflammation and protects us against Alzheimer's. The polyphenols in the fruits and vegetables help with brain health. It improves memory and learning, and it boosts neuroplasticity as well as blood vessel function. The orange ones with our beta carotene and alpha carotene, it protects neurons from oxidative stress. It does support neurotransmitter production as well as cognitive decline and dementia prevention. If we look at the orange and the yellow, it reduces neuroinflammation and antioxidant protection. It does support mitochondria, so we know that's brain energy and production. The yellow and the green are nutrients that's accumulated directly in the brain, which is very rare for nutrients, and they have a long-term cognitive resilience benefit. If we consume the green veggies, that is kind of like the detox of the brain. It does produce or provide cell protection as well as repair of the cells. The white and the light green supports the brain detox pathway. So we don't need to know all of this by heart. If you focus on nutrient variety, we then know that we consume all the various micronutrients that's important for brain function. Then if we look at the gut-brain axis, bidirectional communication between gut microbiota and the brain is happening. We know that the brain health is partly microbiome mediated. So that means that the brain is involved with digestion, it's involved with our mood, it does affect appetite as well. The mechanisms behind this is that it regulates immune signaling and inflammation. So that is coming from the gut. And we know that probiotics and fiber help to keep the gut healthy. And that can indirectly also help with better brain function. If we look at the influence of neurotransmitter production, we know that most of our serotonin is produced in the gut, and that influences mood and emotional stability. Dopamine, that helps with motivation and focus, is also involved in the gut, as well as the GABA acids that produces calmness and stress control. Short chain fatty acids is also digested in the gut from fiber, and that produces butyrate that helps with brain protection and memory, as well as acetate that produces energy and metabolic support. So the clinical implication of dysbiosis is that it does affect cognitive dysfunction. It does also affect our neuroinflammation, so it increases inflammation, and this is basically caused by an unhealthy diet, antibiotic abuse or misuse, as well as lifestyle factors. So which diets are really healthy for the brain? There's a lot of research, but these four are mentioned a lot in the studies. Obviously, the Mediterranean diet takes preference again, and that is a diet that is safe for diabetes and most other health outcomes as well, but especially for the brain health. It reduced dementia risk. It also showed that it improves cognitive function and it improves memory. So the Mediterranean diet consists of vegetables mostly, as well as fruits, legumes, and whole grains, as well as olive oil and fish. So there's your EPA and DHA in your fish again, and it has moderate dairy and poultry consumption and very low red meat consumption. The DASH diet, that's basically used to treat hypertension, also help with brain health, and that reduced cardiometabolic risk, and it indirectly protects the brain. It improves cardiometabolic and cognitive outcomes, and this diet is low in sodium. It contains more fruit and vegetables, whole grains, and lean proteins. And the MIND diet is a combination of the DASH and the Mediterranean diet, and that proved to reduce neurodegeneration and also reduced the risk of dementia, and it improved memory as well. So this diet is very rich in antioxidants with green leafy vegetables, berries, and fish. We also get the Asian plant-based diet patterns that proved to have a reduction in cognitive decline as well as an increase in global cognitive scores. This diet is abundant in vegetables, whole grains, soy, and green tea, as well as mushrooms. And then the Nordic diet was also mentioned in some of the studies. But ultimately, we can also follow the whole diet approach. Healthy foods are natural whole foods. So you see, foods are not processed. They come from the earth. They don't come from a box or a factory. Overall diet quality is much more important than single nutrients.
I think that's a good note to pause on with this presentation. It has been very helpful. We've now seen all the different diets. We know that we should eat a rainbow. I hadn't come across that term before. Very helpful. I deliberately did not watch this before this presentation because I wanted it to be a surprise. Mrs. Van Wyk is so amazing, and she always has something new that I learned from her. I also thought it was very interesting to find out that the yellow and green foods can be absorbed directly into the brain. That's very valuable information for me as a neurosurgeon, and I'll be sure to use that information with my patients. There are diets described. I don't see an African diet described yet, and that's a challenge to us to try to come up. There's the Asian diet, the Mediterranean. Where's the African diet? I'm going to forward this presentation to the place where there are references to epilepsy so that we can get the benefit of that, and then we shall move on. That's just a few minutes.
Problem solving and be creative. We should be emotionally well, where we are aware of accepting or expressing feelings and understand the feelings of others. We should be spiritually well and have a relationship with God. We should be socially well so that we are able to connect and engage with others and be part of the community. We saw in some of the studies, they mentioned that isolation is also detrimental for brain health. And then for our environmental health, we should foster positive interrelationships. So this is wellness in a nutshell. If we quickly look at the ketogenic diet, just a few words on this. It is an established medically supervised treatment for drug-resistant epilepsy. So it's important to know that we typically initiate the ketogenic diet after failure of two or more than two anti-seizure medications. Then we would start the ketogenic diet as well. It is mostly used in earlier specific syndromes like the GLUT1 deficiency, where the body can't utilize glucose, the pyruvate dehydrogenases deficiency, where there's a deficiency in that enzyme, Dravet syndrome, so that's a rare form of epilepsy, and then also with infantile spasms. That's where we usually use the ketogenic diet. The clinical effectiveness of this is that there are higher rates of seizure freedom. There's a significant proportion of patients that achieve more than 50% of seizure reduction. The response is variable. So some patients respond dramatically, others partially, some not at all. And the trial period is usually at least 3 months before we can evaluate whether it's working or not. It does contain high-fat foods. It's very low in carbohydrates. We do try and have adequate protein intake with a ketogenic diet. There is a risk when we follow, when someone is on a ketogenic diet for long term, because it can cause malnutrition and stunting if it is not monitored by a dietitian, because it's typically prescribed as a 3-to-1 or 4-to-1 fat to protein and carb ratio combined. So if you can think of how little protein and carbohydrates we have left to work with, we focus more on the protein rather than the carbohydrates. It provides approximately 80 to 90% of fat from the total energy. There are variants of the ketogenic diet, and it's the modified Atkins diet that's very low in carbohydrates. The MCT diet, where we use the MCT oil in foods, and then also the low glycemic index treatment. So that means that we use carbohydrates that don't spike glucose at all. These approaches are individualized. It's based on the patient's age, diagnosis, tolerance, height, and so forth. And we do calculate it very specifically to ensure that there is at least adequate protein as well. So the success rate of a ketogenic diet, it's typically maintained for about 2 years if effective, and longer duration mostly is in metabolic disorders that we would use it. If you discontinue a ketogenic diet, it should be done gradually over 1 to 3 months. So in essence, ketogenic therapy is powerful, yes, it's evidence-based, and it does treat epilepsy, but its success depends on careful patient selection, very strict diet implementation, and ongoing multidisciplinary monitoring. So thank you for your time, and thank you again for the opportunity. You can like Blue Care Dietitians on Facebook and support us. I also try and make a point of posting education for the public. Thank you so much.
Okay, thank you. I hope that was informative for everybody. Precision ketogenic diet. That's amazing. I think it's wonderful that we have another tool in our toolbox with which to deal with epilepsy, besides the medications and besides surgical therapies. So without further ado, we shall go on to the next item in our program, which is Ms. Kambongi, who is going to speak to us on a mobile EEG program that they studied. And let me see if I can find Ms. Kambongi to unmute, etc. One other word, please, with reference to CPDs or continuing medical points, continuing professional development points. We have applied for them. If we get them, you shall get them, just like last year. As soon as we get them, we shall communicate. So if you'll kindly put your information in the chat, an email where we can send it once we do find out. Okay.
Hi, good evening, everybody. Can you guys hear me?
Yes, we can. We can hear you. We are very excited and looking forward to your talk.
Right. So good evening, and thank you very much, Dr. Salah Chirongo, for the invitation and for bringing us together for what I believe is a very important conversation for Namibia. It is truly a privilege for me to be part of this discussion. My name is Maria. I'm a clinical neurophysiologist from Namibia and currently an Atlantic Fellow for Equity in Brain Health at the Global Brain Health Institute, which is here in Trinity in Ireland. And before coming into this fellowship, brain health for me was very much medical. It was neurology, neurophysiology, psychology, clinical spaces. But being here has really shifted my perspective. And I have learned that brain health is not just medicine, it is all of us. Because at some point in our lives, every single one of us will be affected by a brain health issue, either be it directly or indirectly. And what has been most eye-opening for me is the diversity of people involved in this space here in GBHI. We have artists, lawyers, scientists, clinicians, advocates, patients with lived experiences, and as well as community. And it made me realize that brain health is not owned by one discipline. It requires all of us. And that is something that's very important for us here in Namibia. And that's why when Dr. Salah asked me to be part of this talk, I immediately jumped on, seeing that this is a multidisciplinary approach to brain health. My background is in clinical neurophysiology. I had the opportunity to establish the first neurophysiology lab in the public health sector in Namibia at Windhoek Central Hospital. We started building the service in late 2021 and only saw our first patient in April 2023. And since then, we have done a lot of neurophysiology tests, including EEGs, nerve conduction studies, sleep studies, but majority of our patients were referred for suspected epilepsy. I'm not sure you can see Zoom.
It looks like your screen is not moving. Are you shifting the slides?
I am trying to actually see what is happening here. Let me stop sharing.
We can
I'll
see
stop
the first
sharing
slide.
and then share again, if that's okay.
Okay, that's fine.
Okay. So in GBHI, we've been working on a project for mobile EEG for equitable neurodiagnostic, which is a pilot study focused on epilepsy in Namibia. So electroencephalogram, which is an EEG, this is what provides real-time functional assessment of brain activity, and it supports diagnosis in epilepsy as well as phenotyping across multiple neurological conditions, such as sleep disorders, encephalopathy. It's used in ICU monitoring, brain injury, stroke, as well as cognitive and brain health at large. And these tests, despite it being low cost, it is still a device that's not accessed everywhere. In Namibia, we only have one. And also there is design limitations that affect the usability of this device, especially in like with African hair. And the situation for Namibia is that we have one EEG device, which serves the entire public sector of Namibia, which is centralized. You find it in Windhoek. And we also do not have data in brain health in Namibia. So this is the problem that we have. Namibia only has this one EEG machine, one neurophysiologist serving the entire country, which then creates a critical gap in equitable access to neurodiagnostic care. And this is where our program comes in. This is the current setup for an EEG. The one that we have in Windhoek Central Hospital is stationary, which means every patient comes to the lab for an EEG. Be it ICU patients are wheeled from ICU to the EEG lab. Patients that need the EEG test from, let's say, Katima, Rundu, Ludretz, all over the country, they have to travel to Windhoek for this test. So our objective for this project would like to identify and clinically validate a lower cost mobile EEG device for assessment of epilepsy and evaluate its feasibility within the district hospital. The setup that you see here requires specialized people that actually have to do this test. You have to know the placements, the measurements, which electrodes goes where. It's very much technical, and somebody has to actually be specialized. EEG technicians have to be trained, specialized, and certified by HPCNA in order to be able to perform this test, which we do not have in Namibia. We do not have any EEG technician that is certified with HPCNA. The EEG nurse that we work with in Windhoek Central Hospital was trained by me. We work with a close neurologist as well, and we do this test. But right now, I am on the fellowship. The neurologist is on the fellowship, and there was a point where the nurse was on maternity leave and the lab closed for some time. So this setup here is highly specialized. So the project that we are trying to do is now to, would like to identify a mobile EEG device, which is this device that you see here. From this big machine to just this mobile device that you see there, which then you can connect wirelessly and you're able to read data remotely wherever the specialist that's able to analyze that data is. And it's low cost as well. This setup cost us close to 2 million Namibian dollars, whereas this is just roughly 3,000 euros, which is about 60,000 Namibian dollars. Very cheap compared to that. But there's also another problem. So this system that you see here works in the Western areas, which is it's designed for straight hair. It's not designed for African hair. There's a lot of EEG devices out there, but they are not validated clinically, especially for African hair, for this device to be able to work. And that's where this project is focused on, is for us to identify the device that's actually going to work for us. We want to validate this device and see that this actually works within the hospitals in Namibia, and this is feasible because it doesn't require extensive specialized skills, and it's also low cost compared to the standard one that we currently have. And these are some of our aims. So we would like to develop a structured protocol to compare the standard EEG that we have with a mobile EEG, and also compare the signal quality and clinical performance. So we'll have controls, patients with epilepsy versus normal, and then develop a clinical manual for mobile EEG application, recording, data quality checks, and interpretation. So there's all lots of methods and all of that, how we are going to do this study, which we basically started. There is a big team behind this study. So that is where the work that I'm currently doing comes from. The situation that we have right now in Namibia regarding EEG for epilepsy diagnosis. We are exploring how we can rethink neurodiagnostics in Namibia, how we can move from a centralized system to something more accessible, more sustainable, and more inclusive. So this includes now looking at the technology, partnerships, new models of care that can bring services closer to patients. And I would like to also say that this is not just about a device, and it's not just about a project. This is about building a system, and more importantly, building a team, because brain health in Namibia cannot depend on just specific person. It has to be collective. So I am very open to connecting with anyone who is interested in this space, whether from healthcare, research, technology, policy, community work, because this is an opportunity for us to build something together. And I would like to end with this. Brain health is not a luxury. It is fundamental. And if we are serious about it in Namibia, then we must think beyond hospitals and start thinking about access, about equity, as well as sustainability. Thank you very much.
Ms. Kambongi, thank you very much for the wonderful talk that you gave.
Yes.
It is indeed important to note that any approach to any type of healthcare should be approached systematically and not in a fragmented way. So I'm actually surprised that you said there's only one EEG in the country. Is that in the state hospital?
Yes, in the state hospital, there's only one EEG.
Which means it's in Windhoek Central Hospital.
Yes.
Oh, that needs to be addressed. But thank you very much. Thank you for your talk. We really appreciate it. Thank you very much, Ms. Kambongi, right?
Yes.
Thank you very much. Maybe there's questions from the group chat. Let me just have a look and then see if perhaps there's somebody who has a question for you. Any questions from the participants, perhaps? Do you have a question that you'd like to ask before I move on to the next person? Okay, so now I'm going to introduce our next speaker, and our next speaker is Mr. Munashe Chinyama. who is going to speak on physiotherapy and Parkinson's disease. And he's from Windhoek Physiotherapists. Mr. Munashe Chinyama, please welcome to the webinar.
Okay, good evening, everyone. I think you can hear me clearly now.
Yes, we can.
Okay, I was
You
here
can
fighting and I
screen
didn't know where
share.
to type, where to shout.
I understand. Sorry about that. We had to mute everybody because we had an incident in the beginning where somebody was on but was not able to mute themselves or did not mute themselves. It makes it a bit difficult getting back on individually, but we had to do it. So please do go ahead and you can screen share and get on with your presentation.
That's fine. My name is Munashe. I'm a physiotherapist at Paramount Healthcare Center in Eros. I'm going to share a bit about the role of physiotherapy in Parkinson's disease. So this is a neurodegenerative condition that is characterized by a restriction of movement and reduction of function and independence. And I would want to take it more in a lay sense to give an example of when you have your car and your car has problems with filters, maybe dirty filters. So it starts to jack off and loses power and loses coordination in terms of its acceleration and deceleration. So that's basically the lay sense of understanding of Parkinson's disease, where there's a reduction of the dopamine release in the basal ganglia. But where my role becomes more relevant, it's not the understanding of the condition itself clinically, which most of us, if not all of us, are very familiar with as clinicians, but it's the loss of independence and the loss of dignity, which is where physiotherapy comes in. So it's more than just the dopamine loss. It's loss of identity. Patients start to not be able to do things for themselves. So we sit in the horizon between the clinical pathology and the loss of humanity or the personhood, which is what I just described previously. So in terms of the symptoms that we are seeing, we see clinically that include the bradykinesia, the rigidity, the tremors, the instability. There's also things that are non-motor that include cognitive decline, fatigue, and more relevant as well to the current issues of mental health, and which I remember our MD, Ms. Mroro, was mentioning, the well-being of the person. Often at times, people with Parkinson's disease drop into depression. They're like in their own little world that no one understands, because most people start to sometimes withdraw from them because they feel they become a burden to the family or they need to be helped so much. So depression also comes with part of the diagnosis of Parkinson's disease. And this is something that, of course, is managed symptomatically with medication to manage the symptoms and slow down perhaps the decline. But our insight on that as physiotherapists is we still recognize the fact that even with medication, the symptoms might improve, but the function itself doesn't necessarily get restored, or the decline doesn't get prevented. It might just be slowed down. So what we emphasize as physiotherapists is even in conditions like this, as I'm presenting about Parkinson's disease, it represents still the majority of the neurological conditions where you lose independence, you lose function, you lose autonomy, basically you lose your dignity. But for physiotherapists, we focus on trying to preserve that which still remains. If you're not able to walk by yourself, you still need at least to understand that you still have your independence to maybe eat by yourself or to sit and go to the toilet and maybe walk with a bit of assistance, go to the toilet, go to shopping, or just take a walk around in the garden. So we focus on quality of life to say, what can we preserve and how can we give purpose and meaning to the function that remains in people who are getting conditions like Parkinson's disease. especially as they get older and they get more lonely and they get more removed from society emotionally, because people don't understand their needs as the condition worsens. And this is where we do come in, of course, with various techniques that we utilize, including motor relearning, functional preservation, stimulation, neuroplasticity. We do achieve most of these independence objectives. The usual aim is around mobility itself, to walk and safety, to still have good balance when mobilizing, and still have this ability to perform tasks. It might be playing music, or playing a guitar, or eating, or self-care, and just basically feeling like you're still in control of your life. That's also a role of physiotherapy. And in terms of the tasks, we try to focus on small little tasks that give people a sense of achievement and a sense of self-actualization within the limitations. And for example, for someone who has Parkinson's disease, they would probably feel like they are not able to still knit, for example, a jersey, or to still type a message on a phone, or to still do something that for us wouldn't even think twice, or even just to finish a plate of food. And we collapse the livelihood into small moments, because you can't try to focus on the overall recovery for someone who's very limited and progressively getting weaker. We need to still make them realize that in the small the moments, there is small victories in that. So if you're able to do your own buttons of your shirt, if you're able to tie your own shoes, if you're able to complete your routine, to walk around the block, those are the small wins. And that's also something that in a general neural health sense, we train in rehabilitation. That victory and happiness is in the small moments. Sometimes it's not the full independence that you must focus on. First, focus on the small step. What is it that you could not do yesterday that you can do today? Or what is it that you can still do, but you can do it better? And we still use various tactics, including cueing, where sometimes in the home, when you see that a patient is having cognitive decline with Parkinson's or any other neurological condition, and they maybe forget which way is the bathroom, because you'd see that sometimes they will try to help themselves in the kitchen because they are seeing something that looks like a toilet pot. So then you modify the environment, you cue, you label things, everything clearly, and you guide, just so that they still don't feel embarrassed or like their dignity is taken away from them. Because that's what we see. We still see someone who is still very, very independent, that we want to help as much achieve those small tasks by themselves. And we also look at what they normally enjoy, whether it's playing music, whether it's going to sit and watch a football game, or to go to church and sit. And those are the kind of things that still give life that meaning. And we always emphasize and focusing on still keeping you engaged and involved in all the day-to-day activities. So in a better sense of describing that, we are specialists of preserving what we can't reverse and giving meaning to anything that we can cure. So as far as you start to decline in terms of function, we still want our clients to recognize that there is still meaning, there is still happiness that can still happen even in times of grieving or declining, so much that even if the conditions gets to a point where the patient is now completely unable to mobilize, we still want them to realize that they can still do some things and they can still feel good about themselves, and recognize everything about what they have achieved in their lifetimes, just to still have that autonomy, that dignity, and that participation in conversation. And we as physiotherapists are custodians of function, and we also are very delighted to be in a platform like this, that we are listening very attentively to see and enhance knowledge with our colleagues. I was listening to the presentation we heard about epilepsy, the EEG, the developments that are happening in research, and the projects that are coming up. We are very excited because I think it also helps us to plan our rehabilitation protocols and procedures better when you have more accurate prognosis, foresight with regards to how there is decline or activity in the brain, and maybe the targeted interventions that achieve functional objectives, which will be useful for us to help our patients restore function. So very excited to be learning and hearing about what everyone has to present and add, and also maybe take a bit from what we also contributed as rehabilitation practitioners, so that we bring our patients from being burdens who are very high risk for falls and for injuries and maybe dissociated from their families, to people who have dignity, have function, have their independence, and they can participate socially. Like I mentioned, for some people, just still being able to go to church or to go and sit with a family and sing a song with the parents and the grandkids, it gives that meaning and self accomplishment sense. And just as in closing, Parkinson's disease is one of the many neurological conditions that we work with. As it is a condition that progresses, we still insist that even as the disease progresses, dignity should not be lost in the process. We must modify it, we must preserve it, we must change the experience and make everyone feel good even in the moment of their pain, as we always work with the patients to try and give so much purpose to what they do. Let them feel the small victories, victories in the little achievements that they do on a daily basis. And that's maybe my closing message as well to everyone, that when you're working with patients that have neurological dysfunction or conditions, the multitude of them, our focus, which I'm also encouraging everyone, is to focus on, other than the clinical picture, which what we all know as practitioners, is to focus on enhancing the experience. Make it be a journey of achievement, a journey of shared objectives, fighting together for recovery goals, and so that along the way, even in the process of the pain happening and the limitations happening, the patients can enjoy the ride, they can enjoy the challenges that they will be giving themselves. Thank you so much. I think that was all from my side about Parkinson's disease, the role of physiotherapy, and our general responsibility and role in neurological rehabilitation. Thank you.
Well, Mr. Munashe, you have done us proud. That was not so much just about Parkinson's disease. I would say it's a pep talk and a philosophical talk for all of us about our art of practice. Thank you for bringing that angle. Some of the points that I noted was you talking about self-actualization for the patients, that we should focus on small goals or small achievements along the way. By the way, I'd like to say that there are also surgical therapies for Parkinson's besides the medical therapies. And the physiotherapy. There are also now surgical therapies in terms of the deep brain stimulations. And also there's now the latest one, which was just approved in Japan this February, was the application of stem cells directly to the area which is affected in Parkinson's, to then help that area produce, more of the DOPA that is required, the L-DOPA type of product that is needed to prevent the pathology. So exciting times. China then raced up, and they also have come up with their own solution. So others also in Europe and the US are also working, but the first ones to approve it for public use was Japan, as far as I know. So that's for Parkinson's. I will now go ahead and share a presentation, a very short one, very perfunctory, just to let you know what is available on the market with regard to epilepsy as far as surgical interventions. We've heard the nutritional interventions, we've heard about medicinal interventions, we've heard about the measuring of epilepsy. I'll now just quickly, because time is going and we're almost 2 hours into this. It's gone so fast. I've really enjoyed myself. I shall start right away. Okay, so just an update on epilepsy interventions. I am Aminata Sallah-Chirongo, a neurosurgeon. I'm with Dr. Aminata Y. Sallah Chirongo Medical Practice, which is where I do my clinical practice. Also with Benguela Neuroscience Institute, which is the research and educational arm of my work. More recently, we found a need for a charity arm so that those who cannot afford care will get care. And we're working on that. We have registered a neural foundation. And so watch this space. We'll find out more about that soon. We're also working on a society, a neuroscience society, and it's a neuroscience society, so everybody can participate from every angle. It doesn't have to be a doctor only or a particular scientific researcher. It can be all walks of life. It can be the community who have an interest. It can be researchers. It can be people involved in molecular biology, people involved in imaging. And so again, watch this space. We shall inform you as we go along. This will be quick. It's just about 9 slides and very perfunctory. See here. Okay, so neuroscience is advancing at a very rapid pace. There are paradigm shifts right now, particularly with regard to precision care. Precision care being that we're not treating all patients the same. Everybody is getting their individualized approach because we recognize that everybody is different. Surgical interventions and advances. These are the mainstay of intractable epilepsy. Intractable epilepsy being epilepsy which can be drug resistant, which despite all efforts, the patient is still having seizures. We then look to possibly surgical intervention and surgical interventions rather. These interventions and technological advances enhance the precision rather, and they enhance safety of our approaches. You don't want to have like a B-2 bomber bombing everything around. You rather have like a sharpshooter, something precise and accurate so that you hit only the target and nothing else around it. Prior to this, some of the treatments for epilepsy involved some sort of leucotomies and more open surgeries, which affected other tissues besides what was intended. And we are thankful that now we are getting to a more precise and safe set of procedures. There are, as part of our toolbox, we have neurostimulation techniques. Neurostimulation techniques would include something called responsive neurostimulation, which is a device which sits sometimes intracranially or mostly intracranially to then sense when there are seizures coming on and can stop. So it responses to seizures that are coming on, and that's a very interesting development. Deep brain stimulation, where electrodes are placed within the brain tissue to then modulate brain activity with regard to seizures. Vagal nerve stimulation. Vagal nerve, this is the 10th nerve, which has a very long course, and it has been found that it has an effect when it is stimulated of reducing or preventing seizures. Similar to vagal nerve stimulation, transauricular vagus nerve stimulation, which would involve the ear. The other therapies, excuse the J there, should be an H, thermal, are invasive and ablative therapies. These include laser interstitial thermal therapy, which is abbreviated to LITT, so LIT therapy. If you see that anywhere, that's what it refers to. Lasers are used to precisely go and target areas which are generators of seizures, which particularly in focal seizures, you can target and deal with those problems. There's also magnetic resonance guided focused ultrasound, where sound waves are used instead. They are focused, just like that laser focused, precise to a particular point. And the good thing about this therapy, or these therapies, these two therapies, are that you don't need to make incisions and open the cranium to have an effect. Although they are surgery and they do affect the tissues within. So it's not that they don't do anything, they do affect the tissues. So some people say it's a non-surgical approach. I think it's still surgical, it's still surgery because tissues are being transformed. Other tools which add precision to the work are stereo EEG. So besides the EEGs that have been described, there are stereo EEGs, and what those do are various burr holes are made within the patient's skull, very small ones, and then probes are put in there, and it's stereo because it's recording more than one space, several spaces all at once, trying to locate where the seizure is coming from, with the interest of being able to target that space later on. There's also similar to that where it's actually intracranial. It's the entire surface is lifted. It's not individual probes, but it's like a whole patch that's put on the brain. That's helpful in finding the source of the seizures. And in surgery, it can help us to know where we are and where to touch and where not to touch. Robotic assistance, people are trying to bring in robots to all of surgical work, and that's enough said about that. We are also integrating new solutions in terms of genetic and molecular. So GLUT1, for example, that was mentioned in Ms. Van Wyck's talk. There's genetic work and molecular work going on for being able to address some of those problems that can be sources of epilepsy. Drug-resistant epilepsy or intractable epilepsy, let it be known, is not the end of the world. Most are treatable. Ask for a referral to an epileptologist. If you're a healthcare practitioner and yes, you've seen a patient has tried one medication, it's not helping, you try a second one, it's not helping, patient is also already on a ketogenic diet, not helping, get good diagnosis with someone like Ms. Kambongi and her tools, and we hope that her tools will increase and improve within Namibia. Not we hope, we shall work towards. I think that's a better term to use. We also say ask for a referral as a patient to an epileptologist, or if you're a healthcare worker, look for an epileptologist, a neurologist, epileptologist, to then refer the patient onto. Finally, we must seek for information through portals like ILEA, which are evidence-based and well-researched. The International League Against Epilepsy, which has been mentioned by Ms. Hermina, because we will get good information, solid information that we can use to help the patients, not just any old site online. That would not be good enough. And with that said, that's all I have to say about that. I think we'll open up the forum. I shall go on and enable everyone to speak so that if anybody has any questions, they can raise their hands and come on, or just unmute and make your comment or ask a question. And besides that, then Dr. Amesha can take it away and give a few words and then close down the session.
Dr. Sallah, thank you very much for the closing remarks that you've made, and also more so for the presentation that you made for us. And I just wanted to note that I came across this fact that we actually have in the community epileptologists. Whereabout perhaps may we find these people? Are they easily available at the state hospital, or where can we find if one of us needs an epileptologist? Please, Dr. Sallah. All right, maybe there's a little bit of a difficulty or a challenge with putting her voice back on, but I just wanted to say thank you for everybody that that attended the webinar, and I believe and trust that everybody has gained some very informative knowledge from today's talk. Thank you all so much for being here, and I also ask all of us to carry out this information that we received here, to share it with our family members and with our communities at large, because after all, this is Brain Awareness Week, and brain awareness is essentially for the entire community, starting with us and those around us. Thank you once more for being here, and we will send the CPD certificates via email. Please ensure that you've sent your CPD email to the chat so I can grab it from there, and then we'll send you the certificates. If anybody has a question, I'm going to mute myself now, and then hopefully we can have participants also say something before you leave. Thank you.
So I have taken on being the host again because you asked a question. I was not able to unmute myself. I wanted to say I would actually give that question to Ms. Kambongi, in state and within the ether. I think she had an image that showed that there was a neurologist who was doing a fellowship in epilepsy and would therefore then be an epileptologist. Ms. Kambongi, I'm going to attempt to. Oh, I see you're unmuted.
Yeah,
Kindly go ahead.
So I wouldn't say epileptologist. I would say we do have neurologists working in state. They are also highly centralized in Windhoek, but currently there's a neurologist that I've worked with in Windhoek Central Hospital. She's currently doing her fellowship in epilepsy in South Africa. So hopefully, yeah, I think she'll be back in the country around August this year. So she's the only one in state that I know have gone for the fellowship right now. But epileptologist per se, I highly doubt we have one in state currently, unless in private, but for state we do not. Just neurologists.
Okay, thank you for that answer. I am privy to information about an epileptologist who I know is in South Africa, who is associated with University of Cape Town. She just graduated from a fellowship program in Canada, I think University of Toronto. She did a full year fellowship there and is an epileptologist, neurologist and epileptologist. I'll see whether we can get her to collaborate with us. She is specialized also in epilepsy surgery, so that she can help to monitor and make sure, that patients are properly cleared and properly prepared for this type of surgery. Her name is Dr. Aisha Soini, I think. Yeah, Soini. And so she's at Cape Town. That's the one I know. She's not in town, but we'll try to make links with her and get involved with her somehow. And maybe she can show us the way as far as getting some people here also trained in that field. Otherwise, the neurologist who is specializing in epilepsy is an excellent resource. We look forward to her coming to town and getting involved with the Society for Neuroscience of Namibia that we're working on. And so thank you for your answer and for your presentation.
Thank you.
All right, it's starting to get late. Dr. Mesho, thank you so much for your words. I shall, if anybody raises their hand, I will unmute them. Otherwise, in about 15 seconds, we can close off and close the webinar and close the Brain Awareness Week, which has consisted of radio shows, social media information promotion as far as public education about brain health and epilepsy. We have also asked everybody involved with Brain Awareness Week and beyond to attend a program at the National Art Gallery of Namibia. It's an art exhibition called Togetherness, done by children, very young, all the way to teens. It's an amazing exhibition. I highly recommend it. There are collages, there is polymer work, and it's amazing. You will be inspired. That is through Kaleidoscope Creations, and they are partners of ours with this. So it's free to go and see this at the National Art Gallery. So go, take your family, go with friends, and see what's going on as far as artwork. It's very inspiring, and it is good for your brain health. And it's the brain at work. So far, I'm not seeing any hands raised, and we shall then wish you all good night, happy travels wherever you're going, and that you should have a wonderful holiday. Yeah, so that having been said, if you wish, you may try to put on your video and then say goodbye.